the top of the hour. Good afternoon to everybody east of Thunder Bay, and good morning to the west. Welcome to the Measurement and Monitoring of Safety Collaborative webinar, where in the next hour, we will hear firsthand how British Columbia's Interior Health team from our Learning Collaborative has applied measurement and monitoring of safety before and after the COVID-19 outbreak, and how it influenced their planning for the second wave. My name is Christopher Thrall. I am both a communications officer with and the smooth, silky voice of the Canadian Patient Safety Institute. I would like to welcome you on behalf of our technical host, Alex Titieux from CPSI. I am joining from Edmonton within Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Inuit, and many others, whose histories, languages, and cultures continue to influence our vibrant communities. Think about the traditional territory on which you stand. I invite you to recognize all First Peoples who were here before us, who live with us now, and the 7 generations to come. Please write any questions you have in the Q&A box on your screen or chat them directly to me, Christopher Thrall. They will be compiled and provided to our speakers at the appropriate time. If you run into IT difficulties, please connect with us in the chat box and we would be happy to assist. If you miss part of this webinar or you want to share your learnings with others in your team or your organization, please know that it's being recorded and will be available on our website within the next week. There will also be a quick survey at the end of this webinar. Today, we will be hearing from the collaborative team from Interior Health, and then we will invite the world-renowned Dr. G. Ross Baker to join us for some open discussion. Afterwards, we will share your questions with the participants, so please make sure you get them into the chat box. And now, without further ado, may I introduce our celebrity speakers for this session. Please welcome Director of Patient Safety, Sherry McCown, as well as Naomi Jensen, Manager of Quality Improvement, Patient Safety and Client Experience, and Dr. Nancy Humber, Chief of Staff at Lillooet Hospital, plus Physician Lead in the Rural Surgical Obstetric Network Provincial Initiative. Thank you all so much for joining us today. Why don't you take it away?
Thanks very much, Christopher, and thanks everyone for inviting us to join you today. We are pleased to be part of this learning community and to share our experience. And just to situate where we are, Interior Health is one of 7 health authorities in the province of BC, and we cover more than 215,000 square kilometers, and a lot of that is rural, and provide care to a population of over 800,000 people. Our facilities include more than about 1,400 acute care and more than 7,000 long-term care and assisted living beds. And I'm joining you today from Kelowna, where I'm working from the ancestral, traditional, and unceded territory of the Silks Nation. So today my colleagues and I will be sharing our experiences in using the measurement and monitoring of safety framework and how that has evolved over the past year during a pandemic. And specific to our conversations that we've had at a board governance level, as well as in our rural care areas and with our First Nations partners. So in terms of how we're using this at a board level, in June 2019, we started to report on safety to our board quality committee through the 5 dimensions of the framework. And we began by sort of assembling a map of available safety metrics that were collected at a regional level, and we mapped those to each dimension of the framework. And then over the following year, we started off by taking what we called a deep dive into each of the 4 different dimensions and exploring what safety looked like in our organization through each of those lenses. And then integration and learning is such an important part. We actually incorporated that throughout, and so talked about it within each of the dimensions as we reflected on data that we were using and seeing in each dimension to learn and discuss how we take action across our health system. And then starting in June of 2020 and going forward, the plan was to start reporting on a number of key safety metrics within all dimensions of the framework at every board meeting. And then, of course, in addition to those key metrics, we were also planning on bringing forward any new learning or data around safety that we thought would be helpful for our board to understand and mapped to one of the dimensions in the framework. And then, of course, in March, when the COVID-19 pandemic started, a lot of the new learning and data that we were bringing forward in terms of the dimensions of the framework was then related to the COVID-19 pandemic. So, for example, at our June board meeting for this year, we brought forward the key safety metrics that we were discussing for all dimensions, and then also some new learning that we had from March to June about COVID-19 related adverse events and patient complaints, and we brought that into the conversation when we talked about what we were seeing around past harm. And for example, at our October meeting, we shared data around COVID-related workplace and patient safety hazards when we were talking about sensitivity to operations. And in the future, of course, it's my hope that we will be able to share data around COVID-19 vaccination rates, both for our population, employees, and our medical staff. And this information has been received quite well by our board members at Interior Health. The feedback that they provided us with has been very positive, and they've really found that looking at safety through this framework has prompted a lot of reflection and enhanced dialogue about safety, and really provided a common language around how we talk about safety within our organization. And that holistic view of safety across the system for effective governance, which really has never been more important than where we are now in the midst of a global pandemic. So it's really helped us to frame those conversations and reflect and learn together. So that's just a little bit about our experience and how we sort of shifted when the pandemic began, and how the framework has really helped us to enhance dialogue and conversations around safety at the level of our board. So I'm going to pass it over now to my colleague, Dr. Nancy Humber, to describe how we're using the framework within our rural surgical obstetric network. Go ahead, Nancy.
Thank you, Sherry. I'm Dr. Nancy Humber. I'm a GP. I do surgery, and I'm co-leading this rural surgical and obstetrical network. The reason this has such an impact in Interior Health is although it's a provincial program, the 4 initial sites were in this health authority, and a lot of the work in quality in starting this network started in the health authority. I'm talking to you today from Lillooet, which is part of the Northern Statliam Nation, where I've lived and worked and played for the past 23 years. I'll tell you a little bit about ARSEN to frame the context so we can understand about quality, and also how the measurement and monitoring framework helped with this. The Rural Surgical Obstetrical Network is a provincial program which utilized research to support a sustainable response to the maternity crisis, realizing that there needed to be surgical programs in order to support maternity care. And it basically looks at small sites that have low volume surgical programs underpinning the maternity programs in sustainable models. And we know nationally and provincially maternity care has struggled to find the right sustainable models, and we were trying to find a mechanism to support some of the small sites. And what was really interesting is underpinning all of that network really is quality, and a quality platform of linking the rural sites with the referral hospital, linking rural sites with like rural sites, and really based upon all quality activities. In the next slide, developing the provincial program for quality in small volumes, you can imagine is challenging. As we can imagine, all of the small numbers, it's very difficult to review quantitative metrics as the sole quality program in such small sites, and the measurement and monitoring framework was helpful to maximize the impact of safety and quality in these small sites by embedding a safety culture that was levered really upon the core surgical and maternity teams. As a physician, I tried to find ways to align the activities occurring in the rural sites with some fundamental MMSF questions. And these simple questions seem to really resound with providers. So placing the teams in the center and then looking at questions about how they do their work every day really resounded with them and framed the quality culture in the activities that were already occurring, and also gave us some insight about what activities needed to occur to really make it a 360-degree safety and quality culture. Although it wasn't a deliberate action to plan COVID quality activities within the framework, the pre-existing framework at the sites really enabled a rapid and effective response to the quickly changing surgical and obstetrical landscape that was tasked to them amidst COVID. Without the MMSF, these rural sites had the potential to be significantly affected with the cancellation of surgeries and a small number of critical care teams, and also the impact with the geographic location and their reliance upon providing services to vulnerable communities. And in this slide, you can see that designing the framework around those safety questions, instead of the historical challenge of designing safety around the quantitative metrics, was much easier, and it made planning all of our activities work very well for the sites. In the next slide, I'll explain to you a little bit about how we took each of the aspects of the framework and adapted what we were doing and what we wanted to do in the future. So in the past, prior to COVID, the quality team would meet. They would review PSLS events or patient safety events, morbidity case reviews, the typical past harm, which is embedded in our systems very well. And in the future, what the teams did is really looked at the impact in the past of infectious disease on Indigenous populations. The team met in a collaborative way with the health managers from the First Nations communities and really tried to find out how we could make the Indigenous populations feel safe when they came to the sites to access both maternity and surgery care. What we were worried about and what started to happen is these populations wouldn't access care at all. So as we started to integrate surgery as the measures were lifted and COVID became the new way of doing business, we realized that some vulnerable populations just didn't access any primary care or acute or maternity surgery services. So by reaching out and understanding the past harm impact, we were able to modify our approaches to make the patients feel more comfortable coming to the hospital. In the next slide, we talked about anticipation and preparedness. With COVID, in the past, what we focused on was a lot of simulations, mostly with in the operating room and maternity care, projects looking at decision to incision time, and also simulations bringing the maternity and surgery teams together. With COVID, what we worked on was really COVID-specific simulations, donning and doffing, intubation of COVID patients, COVID C-sections, and this was networked together with remote specialists dialing in to walk the rural sites through these procedures, and as well the rural sites supporting each other in their simulations using remote presence to mitigate some of the barriers that COVID presented with transportation and moving patients and providers around. And I think that this really levered on the success of the coaching as well. Prior to COVID, there were some coaching relationships that were happening between the rural and the regional centers. And through COVID, we levered on technology so that those coaching sessions could occur in real time in the operating room remotely. So in the endoscopy suite, if there was a problem or a concern, a coach from another site would be able to, the regional site would be able to dial in, would be able to actually talk to the endoscopist in the rural site, and the same in the operating room and the emergency room. In the next slide, really focusing on the reliable systems, this was very important during the response to COVID. In the past, we would focus on during COVID, we really focused on process flow maps, so looking at patients coming into the emergency room, into the acute care beds, and into long-term care, really to minimize the risk of patient flow to staff. We adapted the endoscopy flow for the team, looking at an endoscopy huddle in the morning. We would triage the patients according to whether they were AGMP procedures or not, and also triaged according to red, green, and yellow about the timing of it and what team needed to be actually in the room and how that would impact the flow for the day. In the operating room, we had timers embedded if for AGMP, understanding we didn't have a negative pressure room in many of the smaller sites, and looking at the air cycling in order to ensure safety. And also the surgical site safety checklist we embedded through the whole site when doing any of the procedures in the operating room as well as in the daycare surgery sites. In the next slide, looking at the sensitivity to operations, while pre-COVID attention was really spent addressing surgical benchmarks and provincial directives and quality local team meetings, with COVID, we shifted gears into really linking the maternity and the OR programs and aligning all of their processes for triage so that they had the same coding for the COVID red, yellow, and green, so that the patients could be stratified and minimize risk to staff and patients, and daily monitoring of wait lists and triaging for urgency, depending on the whether the procedure was AGMP and whether or not the wait list was accurate and up to date, so that we could gradually start to clean up the wait list and address that as the surgery program started to open. And in the next slide, I would say that the team function didn't change very much for COVID, but a highly effective team was extremely important in adapting and responding. The sites that had the most effective teams were able to switch gears very quickly and address the increased need for change in processes, and to ensure that tracking quality and safety through process measures were embedded in everything that the site did. And without the highly effective team, I think that it would have been difficult for these sites to respond. And we really levered highly off the OR and the maternity teams, knowing that they are the core services really in the small hospitals, and as well respond to critical care in the emergency department. So we levered off that highly effective team and really built up simulations with those teams and embedding high-level communication within that team function. So overall, COVID was an important test of the safety and culture at the sites, and that MMSF framework enabled the sites to efficiently respond and adapt by having some key principles prior to COVID in place so that the sites could really adapt and respond. So I'll pass it on now to Naomi, who will share some of her experiences in the work with the First Nations population.
Thank you, Dr. Humber. So I'm calling in this morning from Kamloops, BC, where I am very proud to be living, working, and playing on the Secwepemc Nation's traditional, ancestral, and unceded territories. And really my focus to present to you today is around our connection and learning from our First Nation partners during this pandemic. As I'm sure all of us are busy learning as we're building processes, I think Nancy's presentation really highlights where some of what we were finding in a bit of an after-action review, although it was kind of partway through the first piece of our journey as we learned to prepare for the second wave that we're experiencing right now. So what we did was reached out to First Nation partners to see if anybody was interested in sharing their story of their experience to date. And really what we wanted to understand was what things were working well and what opportunities for improvement did we have that we needed to help continue to work on. So really the process that we put into place, so we were very thankful. We had one of our larger nations reached out and said they were really interested in joining us with this review that we were doing. And so we hosted two 2-hour focus groups, and this was all based on the time and what they wanted to see. So it was a collaborative process as we developed this. And so we hosted these focus groups to really listen and truly hear what they were saying. We didn't come in with any preconceived ideas. We just let them tell their story. So we really focused it around what's working well for you, what opportunities do we have, and what other sorts of things would you like to share with us regarding our health authorities' ability or journey to responding to the pandemic. Along the way, we just asked some curious questions and really just allowed the dialogue to flow. From the focus groups, we were able to then develop an action plan, and we committed to some really active follow-up and engagement with the nation partners. And this was really, really important in the work that we were doing to build those trusting relationships. And so our action plan, we got many things kicked off, and then lots of them, of course, as the pandemic is continuing to unfold. Some of them are a little bit longer targets, and so we are continuing to work on those. Through the process, I gathered a lot of information, and I was sitting there trying to think, oh goodness, how am I going to pull this together in a really meaningful way, so that our leaders of our Pandemic Response Coordination Center and at the local level have some really useful information and can see the connections in the stories that our partners are telling us. So I had an idea, and it was really to use the framework. So what I did was, when thinking about the stories that were shared, of course there was that piece of the historical trauma and the barrier for many Aboriginal people seeking care outside of their home community. Dr. Humber spoke really well to some of those challenges and those opportunities to improve systems of care, to really support and wrap services around the community. So there was also some things which were not new for us, but that COVID was posing a new challenge, was trying to figure out roles and responsibility and clarity between our local nation, Interior Health, our First Nations Health Authority, the Ministry of Health, and all sorts of other partners that are working together to respond to the pandemic. And sometimes it was a little bit tricky to understand who was doing what or whose role was what, and so really trying to figure out those pieces would be really important. We could say this is a little bit of reliability maybe in a system, but because it was not new and we are all learning to come together, I kept it over a bit more into the past harm part, because we already had that understanding and we're working towards improving that system. So then I formed it into some of our reliability. So are our clinical systems and processes reliable? So we know that often when we're looking at systems, communication is a root cause, or lack of communication can be a root cause of lots of trouble that we can get ourselves into. So of course, improved communication came through. And again, that was a lot to do with the different layers and all the different players, right from the provincial and regional work that's happening right down to the local level. And because with the pandemic, we are all working at such a rapid pace, sometimes bits of information come and go, and it's a challenging time to be in. So we recognize that part. We did know that testing and assessment at this point in time was working really well. The local team had the supplies and all the things that they needed. So that was working well. Our nation partners, the nurses and the team there were busy doing the work they were doing, having a wonderful collaboration with a local operational team. And so also through the process, we learned that they really appreciated our local operational leadership for all the work that they are doing. So they are busy building things and collaborating with the team, and a lot of it Nancy even spoke to, and so they were really appreciative that we are building all of these things as we go. And so one of the things that came up, for example, with us was with our lab samples. So we're doing the testing and the assessment. We're working within our small rural communities, and so our local operations work to develop and expand different services and times and ways that our nation partners could get those tests and those samples over to the lab so that they could be processed in a safe and timely manner. So lots of things were going. we did also learn that contact tracing comes with some real opportunities and some challenges for our Aboriginal communities, and so we really need to be mindful of that when we have individuals that maybe do not have a fixed address or maybe live in multiple homes depending on what's going on. So we really need to have those collaborative processes with the First Nation communities, especially when working on reserves, to make sure that we're able to do the job well. And of course, woven all through this is still the historical trauma that First Nation peoples experience, and so really trying to be mindful and create meaningful work around that. Also, the concept of self-isolation isn't really super reliable within the communities, especially when you're looking at some of the housing challenges that we have, and we have multiple families living in one home and there might only be one bathroom. And so trying to really work around that and build new systems of care, which we are doing, and trying to anticipate where our next steps will be. So when we think about sensitivity to operations, our partners really felt that right now at this point in time, although we have low numbers of COVID, and actually even when this particular review was done, we were sitting very low. And so we were fortunate to not have to have experienced huge surges and volumes. And so at this point in time, the partners were feeling supported with the COVID processes. But really we wanted to understand more of it into our anticipation and preparedness. The other bonus is that our partners are part of all of our working groups, and they're proactively working with us on our COVID-19 processes. So having their voice at the table helps us honor and respect the needs that they are bringing forward. Anticipation and preparedness. Now this one for us was really the hard part. So this is where the stories really pulled your heart and your brain all at the same time. So as Dr. Humber spoke about, when people are wanting to maybe leave or feel safe to leave their community to seek higher levels of care, and with our COVID visiting restrictions that most of us have, of course not being able to bring full families in to be right there at the bedside, having support systems kind of, I guess, skinnied up a little bit, adds to that fear and that the trauma that is being experienced. So the pandemic brings lots of unknowns. So it's always those questions of what if this happened? What would we do? How would this work? And so we're really busy building lots of tabletop exercises to test processes that we have never had to experience before. So there's lots of questions that will remain under anticipation and preparedness, as the pandemic will continue to throw us curveballs from time to time. But we are doing our very best to try and anticipate and be prepared for what the future might hold. And integration and learning. So are we actually responding and improving? Absolutely. So our teams are taking all of this information and actively working on our systems of care. We're seeking input and ideas from community partners and all over the place, and we are actively testing and trying new processes each and every day. So by taking and using the framework, it really helped us formulate the learnings that we had from our First Nation partner discussions and look at them in a real holistic way to understand what was going on, where we maybe were doing well, and where opportunities for ongoing improvement happened. But would I use the framework again? Absolutely. I actually think on reflecting back, I might actually even consider looking at how I would use the framework differently, even more upfront versus at the back end of formulating the report and all the information for our leaders. And I think it's just a really great way because it helped us really understand where we were doing well and where those opportunities for continued work was going along the way. So thank you. And I will pass it back over to our CPSI team to continue the rest.
Wonderful. Thank you so much for that. Sherry, Nancy, Naomi from the Interior Health team, really appreciated your time and your presentation there. Please remember, any of you can write any questions in the chat box, send them directly to me or to all participants, and we can ask our interior health team about the questions you have. Unfortunately, Dr. Ross Baker was unable to be here with us today, but please welcome Mr. Wayne Miller, a Senior Program Manager at CPSI with over 30 years of healthcare experience. He was a coach with the 2017 MMSF demonstration project and is the CPSI lead for the current Measurement and Monitoring Safety Improvement Project. Wayne, why don't you lead us off into a discussion with the Interior Health team?
Thanks, Chris. Thank you very much for the wonderful presentation. I'm just going to explore a couple of the interesting threads that I picked up through all the presentations, and that is one of the things that I hear through all of the speakers was this idea of ensuring sort of the communication lines are kept open and sharing. So Naomi, in your presentation, with working with the Indigenous population, the importance of setting those things up so that you can actually hear and share stories. Just wondering if you could expand a little bit about what you did as sort of prerequisites to ensure that good communications would occur. What was sort of the background, the setup for that?
And Wayne, do you mean within the focus groups or just in general of knowing that we needed to work on some of our communication?
Within the focus groups, the structure that you used and how you came to get those people, the specific participants and things.
For sure. So with the team, so what was really important was that we are definitely learning with our First Nation partners is that we reach out and then we allow them to offer the opportunity. And if they would like to join us, then we worked with their local team. So they actually have their own emergency coordination center or operations center. So we worked with their team to develop and set that framework or the framing for the event. And what I found really interesting was that we started out with a 2-hour session. And I just introduced myself, and we tried to keep it as safe as possible. What I think also worked well was that their EOC structure, they were able to already formulate some ideas. So we were able to share and kind of talk around some of those things so that if some of our team members that we were working with maybe didn't feel like they were able to share their story, we were able to bring some of those themes forward for them. What I did find very interesting was, I tell you, it's, I've done a lot of cultural safety and humility training, but when you're speaking to First Nation partners and you are hearing those stories, and I felt absolutely honored that they spoke straight from the heart. It was extremely passionate and, being very respectful and thankful for that and recognizing that right there in the focus group seemed to really help others. Then more stories started coming forward, and I think also not challenging them. My intent was never to question their story, but ask some curious questions to be able to dig in a little bit deeper. So I think it did help really frame. And from the first 2 hours, they actually asked me to come back for another 2 hours. So clearly something worked right in the first batch. So.
Wonderful. I've seen this happen so often through our work with measurement, monitoring, safety, and even before that. But just how willing people are to come and to have these open discussions with teams to improve healthcare, and that willingness then to accept the comments and to really hear what people are saying is so important. We've often talked in measurement, monitoring, safety about this idea of imagined work versus real work. And I guess one of the things I heard through your story, through your presentation, was this idea that lots of times you maybe have imagined that things were occurring one way, but the stories you were hearing were sort of probably sharing a different perspective on it. Would that have been the case in certain times?
I think so, yes. we can put those theories in place and different algorithms, and we can appreciate those, but then when it comes down to actually how it might happen in that local context, and I think that's where for us it was that anticipation and preparedness to be able to adapt systems and processes. And I think Nancy or Dr. Humber spoke very well to how some of the things that they've adapted at their local level have really been influenced by the Aboriginal peoples from their community. So,
Thank you. Dr. Humber, you talked a little bit earlier about highly effective teams, and it's something that we will occasionally talk about as a team being highly effective. But in your perspective, what is the secret sauce that kind of makes these teams effective? Like, when do you know you've got a highly effective team? Because we oftentimes, it's easier to pick out dysfunctional teams, but what is it from your perspective that really kind of makes that highly effective team?
Thanks. I think my thoughts about highly effective teams go all the way back to experience in maternity care. And I know that in maternity care, a lot of the movement with the MOROB program is how do you get your team to be highly effective, and what are the parts of that are highly effective? And in addition, how do you measure it? So embedded in the MMSF that we're doing in all of the sites is actually measuring team function. So looking at things like communication, how knowledge is shared, how comfortable people feel speaking up if they see a near miss, if people feel valued and supported within the team, and allowing the teams annually to be able to see how their team is functioning and to see which areas they're doing really well at and which ones they're doing not so well, and try to adapt their team activities, simulations, learning, and time together to address the aspects of team function. And I can give a great example just in Lillooet itself. We have a very, very good team that really moves from the maternity ward to the operating room and has worked together for a long period of time. And it's a very small team. And what happened about, I think, 8 or 9 years ago is a lot of the older nurses retired and the new grads came in, and we didn't actually realize that that changed the team culture. And one year when we were looking at what we were doing well and what we weren't doing so well, we noticed that it came up as a flag that people didn't feel that knowledge was shared, that there was hierarchy within the knowledge, that the physician group held the knowledge and didn't sort of pass it on to the nurses. And what we did is we did lunch and learns together, where the physicians and nurses would learn together, and we did it every Thursday, really quick 20-minute touch base. And the following year, we noticed that metric actually increased, but without strategically saying we need to understand how our team is working together and what they're doing well and what they're not, you actually don't know how to fix it. And I think we do notice it if it goes on over time, where the team function starts to deteriorate, that the teams, we can go back and say, oh, we noticed that this was happening over the past few years, and that knowledge was had hierarchy embedded in it, and that people didn't feel comfortable in the team. But without doing it annually, I think it waits for things to get worse before you actually understand what's happening. So I think that's what I mean about team function. And the other thing is, I think it's also a reflector of capacity. So if teams are functioning very, very well on the ground, they have resilience and capacity to adapt. And one of the things in smaller sites that's super important, I think, is to avoid voltage drops. So when there's a program or a process measure that has to be implemented, that regionally makes a lot of sense, but as it gets implemented into the smaller peripheral sites, the local context becomes so important that the process measure may not actually make sense anymore. So if the local teams are very highly effective, they can take that and adapt it and make it work for their site. But if they don't, it doesn't work as well. It just gets implemented as is without the flexibility and adaptation. So I think those are a couple of examples of how highly effective teams are really important, and that by putting a lot of strategy and value in highly effective teams, the teams are able to adapt to COVID or whatever change is coming in the future.
I love this concept of voltage drop, and I'm just wondering if you found that the time during COVID is actually enabled voltage to remain high, or actually kind of just helped with team dynamics a bit more, because people, I guess what I'm wondering is if people come to the table a little bit more prepared to work collectively, or to break down some of those barriers.
Yeah, it's an excellent question, because one of the things that I noticed with COVID is because it disrupted the system so much, that one of the problems that happens in the smaller sites is if processes are too firmly embedded, it's very difficult to adapt them. But when the service in general is very disrupted, it's easier to adapt. And one of the things that the surgical network was able to do is really network the providers together. So on a provincial basis, these teams would be sharing and learning together remotely about what are you doing with COVID intubation? How are you managing your decision to incision time with the new process measures to make COVID safe? How are you doing COVID embedded in your endoscopy team huddle? And by sharing with like sites networked together, embedded in those core quality teams, they were able to lever off more like sites and have the empowerment and actually be able to see how to adapt the measures to their own site. And that was really empowering and rewarding for the site, and it really did allow them to be ahead of the ball. So they had things in place, I think, long before others, because they were very motivated at their small sites to get everything enabled to work right away. And because there was less people involved, they were able to respond very quickly.
Interesting. Yeah, that opportunity that there's a silver lining in the clouds at times. Sherry, I want to just talk about the board for a quick minute. And you referenced this idea of the common language. How have you seen that grow at the board level, the use of the common language? And I know this is a bit of a journey, but do you have any advice or guidance to people that are trying to establish a bit of a common language at the board level?
Yeah, absolutely. And we've had a number of the other health authorities actually in BC reach out to us and wanting to start sort of a similar pathway with their board members. And what we have found is that it really is an evolution. And it's something that it took us a year to sort of get this off the ground. And throughout that year, we were sort of constantly talking about the framework, and more than just the dimensions of the framework, but really asking those 5 key questions. Has patient care been safe in the past? Is care safe today? Will care be safe in the future? Are our clinical systems and processes reliable? And are we responding and improving? And really coming back to those foundational questions. And even at a board governance level, it really helps to frame the conversation and provide that common language. But it's something that we bring up again and again. So it's always about situating the conversation in terms of where we're at in the in our conversation and where we're at in the framework. So coming back to that again and again would be some advice I would provide. And always sort of hammering home those fundamental questions that really prompt that reflection to occur. And what we found at Interior Health is that as we did that over a full year, we really were able to move our system from one that was sort of situated pertaining to safety from a really retrospective lens, and instead sort of moving that along to a model of assurance and one of inquiry. And so it's about reframing that conversation to be more curious, and those key fundamental questions that are so simple really help us to do that.
It's interesting because being a board that has practices this level of inquiry can sometimes feel a little, may feel threatening to leadership at times. Like, why are you asking these questions? We brought this information to you. So I guess it meant both parties, both your senior leadership team and your board, collectively understanding this process and working together move it forward. That's an assumption. I don't know if you have any thoughts on that.
Absolutely, and our senior leadership team is a really important part of this. And I found, just personally, having been involved in these conversations at the board and senior leadership tables, it's been very humbling actually to reframe our questions in this way and understand safety sort of beyond that retrospective lens and more sort of looking at what's coming in the future and are we prepared. And that self-reflective process is one that I think has been good for all of us.
Mm. Do you have an aha moment in there anywhere during that journey that you'd like to share?
Well, I think, for me, it sort of came back to the idea that, when you report to the board or you're bringing things forward to the board, you often sort of rely on your quantitative data. But I've actually found that our qualitative data, and particularly our stories and case scenarios that we've brought forward, really help to bring this to light for our board members and have really enhanced our conversations. And so for me, that's my aha moment, is just valuing that importance of the qualitative side of things. And recognizing that some of those shared stories and some of those experiences, particularly from the perceptions of safety from our patients and families, are absolutely crucial to be able to really understand what's going on at a high level.
Yeah, wonderful. I know my colleague Anne would be quite thrilled to hear you talk about the qualitative. She's always talking about utilizing the soft intelligence and how do we get people to utilize that. So that's great. Christopher, I think there's a couple of questions in the chat box. Do you want to?
Yeah, you betcha. Thank you so much, Wayne, Sherry, Nancy, Naomi. This has been some terrific conversation here. We have been receiving a couple of other questions from the chat box, so I thought we could open up the floor to all our speakers. But first, a little bit of a rave for the Interior Health team from Ainsley Young. Well done, Sherry and team. Your work on the revised board reporting has prompted Island Health to change ours. So thank you for leading the way for BC. Thank you, Ainsley. It's wonderful. Kudos for them. First off, though, I have a question for Naomi Jensen from Teresa Malloy Miller. Hi, Teresa. How did people who shared stories receive feedback about the effect of them sharing their story?
Good question. So one of the ways that we did this when I was hosting the focus groups, we were taking away the opportunities for improvement, and I very quickly collated them into a quality improvement action plan. And so I think also this probably does lead a bit more into also what Wayne was asking about, setting the stage. So we did commit to that, the transparency and actively working. So we did hop onto it really quickly, and so with our action plan, we made sure that we were feeding that information back to the team so they could see that we were actively working on it. We kept it safe, so we didn't say, Naomi said this. It was just really very factual. And so really each time that new information or new things came in, we were just continuing to send it back. And then at the end of it all, because a lot of actions were completed within a very short amount of time, but some of these, as we're still anticipating and preparing, are longer term improvement opportunities or systems that we're building. And so just reaching back to the team and kind of closing this and then ensuring that they are at the right tables to continue to work collaboratively with the health authority on some of the things that they have determined are really important to them, and then ensuring that they also had key contacts. They knew their local operational team was there, but also our executive director, and that as going forward, if ongoing opportunities or concerns from them, they had key contacts to be able to, which they knew, but we just wanted to reinforce that. And so actually through the whole process, it was really great because they did come back and they did express gratitude and appreciation for the process itself just as much as we were so thankful for them sharing their story and being open to it. So I think it's that transparency and active engagement, and sometimes just being also honest where we don't have some of the answers. So that was really important, and where they could, I think, really see that their voice was helping to change the system.
That's terrific. Thank you so much for that, Naomi. I have a follow-up either for you or even for Wayne from Shannon Moore. She loves the idea that you use the framework as a way to think about and evaluate what you learned. They've also done this at STARS. They were wondering whether you actually had more success in just asking for a story as opposed to thinking more about it as a framework approach up front. And she wondered if CPSI also thought about encouraging its use that way. What do you think, Naomi?
I think actually when I think about the framework, actually the focus group to me kind of digs us into more of that sensitivity to operations. And then I would agree, just allowing the story to flow was really important. And then us framing it, I think, added that value and meaning for us as the health authority. Yeah, it's a good question. I've often wondered, because I thought, would I actually frame a focus group using those particular questions? I might use them as maybe prompting curious questions, but I'm not sure, because I would worry it maybe might. I don't know. I think it would depend on the group. I don't know. What do you think, Wayne?
Yeah, strategy or tactics, Wayne. What do you think?
No, I would agree with Naomi, and I was reminded of some work that we had done in Saskatoon with the program there, prenatal a kidney health program in Saskatoon, and I remember that they had some people come in and tell their story, and they were at the time, and I'm sure there might be people online from Saskatchewan, but they had done a lot of work using lean, and they actually had mapped out sort of a process map on the wall, and when I say on the wall, this story was marked right across the wall. It was like sitting in a boardroom with the story marked around the wall of the boardroom. And you know, when they first went through the story, they were using their lean tools, their skills that they had developed in lean. But afterwards, through the use of the framework, when they looked at that story, now the lenses of the framework were being applied. And I think, you know, we keep saying that this sort of rewires your thinking about safety. And I think the framework truly does that. After you use the framework for a while, you tend not to look at the problem the same way. You'll approach the problem in a different way. And I think that becomes the benefit of the framework, because whether it's at the board or right at the front line, when you can look at a problem using this simplified common language, but know which lens you're looking at that problem through, it helps you, you know, really, I guess, be able to find a solution, to identify that problem and to be able to find a solution for it. So I think, you know, I don't know if there is a right or wrong answer to it. I think as long as you're applying the lenses of the framework, I think it's a good place to be.
Fantastic. Thank you so much, Wayne. Appreciate that. I do have a question, actually, and I'm going to throw it over to Nancy Humber, because there's a little discussion that's heating up in the chat area there. Eshiray Chowdhury asked about the COVID context. It's highlighted the importance of social determinants of health right now. To what extent have these variables, these social determinants of health variables of the stories, impacted concepts or execution of the measuring and monitoring of safety framework? What do you think, Nancy?
I have, I think, one piece. It's a very broad question, but I know that vertically connecting everything through the measurement and monitoring framework is really helpful. So going all the way to the ground and asking patients and embedding them in planning on local working groups was really helpful. So we went all the way out to the actual communities, so the Indigenous communities where there is historical gaps in access to care as well as a heavy burden of social determinants of health. So we did ask what mattered to them, and we designed some of those metrics in the patient experience of care. And in reality, we changed our questions. So some of the questions were things like, have you done drumming today? Have you spoken in your own language today? So we embedded those as what our metrics of success are about overall experience of care and overall holistic health and wellness. We brought that up as well into the mid-level planning, so putting all of that information together and looking at how can we mitigate some of the barriers in access to care during COVID. So looking at making the front of the hospital welcoming, looking at how do we message to the First Nations communities how to safely access care and to ensure them and assure them that we have processes in place to ensure when they come to the hospital it's safe for them. We also took the providers and virtually connected them to the communities as a transition or gap between face-to-face care, so that there was a bridge between no access to care and face-to-face access to care by virtually embedding that. So doing perioperative consults in Indigenous communities, doing post-operative care virtually so that the teams still were connected to populations which historically have had difficulty accessing care. So I guess then connecting that as well all the way up into a provincial level, looking at how do we evaluate patients' experience of care and that the systems we have in place address systems needs. So we would adapt and evaluate our program based on patient experience of care as well as access to care metrics that we would track, and also looking at provider experience of care as well about whether that was a sustainable model and whether or not they felt valued working in those specialty populations able to access or provide care to those populations. So I guess just an example of how you would take that from the ground, move it to the middle layer, and then also on the provincial layer addressing that.
I like this a lot, and actually, Nancy, I just want to ask you, is this a sort of ongoing adaptation of the measurement and monitoring of safety framework a feature of the framework of the collaboration, or was this something that you decided you had to adapt while you're boots on the ground and you're figuring out how to actually execute it?
I think for me what it was is it was difficult to figure out how on a provincial level to bring together so many pieces. How do you bring together maternity services, surgery services, physician distribution and resources, specialty population, sustainable models of care, and quality? And it seemed like there was all very many smaller initiatives that spoke to little pieces, but there was no one way to integrate it all together. So learning about the measurement and monitoring framework was actually a way to bring it all together, but actually allow each of those little pieces to evolve and iteratively adapt moving forward without disrupting the whole framework. So it was actually very valuable in the beginning before COVID, but you could really see that having that framework approach, having to rapidly respond to COVID, how we did it better because the framework was in place prior to that happening. So that was very interesting for me to see that.
Fantastic. Thank you so much for that, Nancy. I really appreciate that, and a fulsome answer as well. Unfortunately, I do see that we are at time, so I want to respectfully thank Sherry McCown, Naomi Jensen, and Dr. Nancy Humber, as well as Wayne Miller for stepping up and sharing your time and expertise. Thanks to all of you as well for taking the time to attend. On behalf of me, Christopher Thrall, technical host Alex Titia, and the rest of the team here, please take a moment to respond to the survey that has popped up in your chat window before you leave. If you want to continue the conversation started in this discussion, please feel free to send us an email. We will forward your comments and any questions you may have had that were unaddressed onto our speakers. We'll also post a recorded copy of this webinar and the slides on the CPSI website in the next week or so. Join us online at patientsafetyinstitute.ca for additional resources. Visit our YouTube channel at Patient Safety Canada and learn about each team's successes through the collaborative. Have a wonderful day, everyone. We will look forward to seeing you again soon.